Hello everyone. So now we will be doing the INICT November 22 OBG recall. This is a part 1. Okay. So here I would like to say to all the NEET PG, all the FMG students, that one who thinks that these questions are of INICT, they are not important for us. It doesn't matter to us. Our paper is of basic type. So I want to edit here. Keep this time the INICT November 22 was more or like basic. It was from 80 to 90% PYQs. The whole 80-90% paper was from the previous PYQs. Okay, and only 3-4 questions of the OBG was there, for which I have to open Williams. Otherwise all were from the previous PYQs topics. Okay, so all the FNG students and all the NEET PG students, here I would like to tell you one more thing. Or any examiner who will sit your paper will see this INICT November 22 trends. So you should be thorough with these topics, and especially thorough with the content, this topic, the concepts this INICT wants to tell you. Okay, so let's start it without any further delay. So this was a question that identify this image. Okay, this was an image given. Then this is the abnormal placentation. So as you can see that here there are two lobes of placenta. Okay, two placentas. This is a small lobe, and this is a main placenta, and this is a small part attached somewhat differently. Okay, so I have explained this question in detail because some of the students with whom I am in contact online, they were telling that कि ma'am, we are not having difficulty in understanding this placenta. So I have explained this only question in detail. Rest all will be in a running mode. Okay, so let's see what is placenta succensurata. The image which you saw was of placenta succensurata. Okay, what is placenta succensurata? Is the small lobe is there attached to the main placenta. Okay, a different small lobe is there attached to the main placenta, and these lobes, they are connected by the blood vessels. Okay, these lobes, they are connected by the small blood vessels. Okay, and what are complications you have? So this can also be asked by the examiner, and they have asked previously it's a PYQ. So I would like to tell you, when delivery occurs, the main placenta, it comes out, and the main placenta, it comes out, and that small part, it is left inside the uterus itself. Okay, and that all that the left placenta, it lead to subinvolution of the uterus, sepsis and pph. Okay, because even that is a small lobe, even a small membrane is left, then also it leads to pph, secondary pph. Okay, and if anything is left, it will of course lead to subinvolution of the uterus, because uterus will keep on trying to expel it, and it leads to sepsis, because again it is a source of infection. And as you all know, the placenta is made up of lobes, chorionic villi, so it will harbor the bacterias and the viruses over there. Okay, so that was all about the placenta succensurata. So whenever you see two lobes, one main placenta and a small part attached to it, along with and connected by the blood vessels. Okay, so here you can see that here these are the blood vessels connecting it, right? So then it is going to be the placenta succensurata. Now let's go to the another placenta, which is circumvallate placenta. This is quite difficult to understand, so first let's understand the basics. Okay, this is the, yes, this is the chorionic plate. Okay, what is a chorionic plate in the placenta? Where to the side where umbilical cord is attached, it is chorionic plate, and at the end, this chorionic plate, net here, this is, are you able to appreciate? A green color line is there, and a blue and a brown color line is below it in the chorionic plate. See, this is the amnion, and this brown color line is chorion. Okay, and when these are coming, and this is the lower, this one is the decidual plate. Okay, this lower one which is attached to the uterus side. Okay, this is a decidual plate. And when we will say that this is amnion and this is chorion, and when we will say that yeah, from here the chorionic plate start, so here answer to that is, we will say that chorionic plate has started if chorionic villi comes out of it. Okay, so you are seeing that I have to change the pen. Yes, from here the chorionic villi is coming. So these are the chorionic villi. So now we will say that before this whole part, this is amnion and chorion, and when chorionic villi comes out, this is known as a chorionic plate. Okay, so what happens in circumvallate placenta is that the chorionic plate is short, is small. Okay, then the decidual plate, the one which is below it, okay, so is small. Then so what happens here, the so here you can see that, yeah, so which is the chorionic plate, this is the chorionic plate, this much, and these are the amnion and chorion. Okay, so these are the amnion and chorion. Okay, these are the amnion and chorion, and this is the chorionic plate. Are you getting my point? Okay, and this is the lower one is the decidual plate. Okay, so you are seeing that this chorionic plate is very very small as compared to decidual plate. So what is happening is that these amnion and chorion, they fold here. This amnion and chorion which I told you, they fold here. Okay, now this amnion and chorion, they fold here. Okay, like this, they fold here, and below it there is deposition of the fibrin, and here this blue color is the fibrin deposits. Okay, this amnion and chorion folds and there is deposition of the fibrin. Okay, right, are you able to understand? So now you can see here in the pec that this is the chorionic plate. Okay, and this is the folded amnion and chorion over it. Okay, folded amnion and chorion over it. Okay, and below them is the fibrin deposition. Below just this white color is the fibrin deposition. So this is the fibrin deposition. Now this fibrin deposition, it leads to APH, antepartum hemorrhage, that is premature separation of the placenta, and it leads to IUGR. ठीक है, and it leads to IUGR because as you know, I have already told you that chorionic villi बहुत कम होते हैं, because chorionic plate is small and chorionic villi कम होते हैं, तो उतना proper nutrition नहीं जा पाता. Okay, so once again I will tell you that as the chorionic villi are lesser in number, because the chorionic plate is less in size, so the villi are less, so nutrition going to the fetus is less. Okay, so it leads to mainly two complication. Number one is APH, because this fibrin which is deposited here, it leads to premature separation of the placenta abruptio, and due to the less number of chorionic villi, it leads to IUGR. Okay, do you got it? Okay, next is Battledore placenta. What is Battledore placenta? So usually the if this is placenta, then the umbilical cord inserts in between, but in the Battledore placenta, as you can see here, it is inserting here in the periphery. Okay, so cord is inserted at the margin rather than inserting here in the center. The cord gets inserted in the margin. Okay, So that is about the battledore placenta. Okay, next is filamentous in next is filamentous insertion of the cord. Now you all know, as I have told you, that if this is the placenta, then cord inserts here in the center, and then within the placenta this cord divides into lot and lot of branches. Umbilical cord has three vessels, one vein and two arteries. Okay, so then these vessels, they divide inside the placenta. But if this splitting of the vessels, it occurs before the placenta gets inserted, and so that is filamentous placenta. So it means that the placenta is getting inserted at the membrane. So now you can see here, this is the placenta, okay, and this is the umbilical cord, okay, and this cord has splitted before entering the placenta, right? See, this has splitted before entering the placenta, okay, and it automatically, it means that this cord has been inserted at the membrane. Okay, it has rather than inserting in the placenta, this cord has inserted in the membranes. And now, this is also known as filamentous placenta, or it is also known as membranous placenta, because the insertion of the placental cord, umbilical cord, is at the membranes. Okay, now what the complication it leads to, it is vasa previa. Now let's see understand it with this help of the diagram. This is the normal, this one is the normal placentation. So as you can see that this is cord, it going and inserting here. But as in this membrane, the splitting occurs before. So the length of the cord gets extended due to the splitting. And now this splitting, when they come below the head of the fetus, then during the pains, when the fetus head puts pressure on the pelvis or engages itself, then this vessels, now they are not covered with Wharton jelly, now they are lying there naked. So this vessels, they break, and vasa previa, it leads to vasa previa and rupture of the vessels. Okay, so what is vasa previa? That vasa previa is vessels, I'm not telling cord previa means it is in the lower uterine segment, because when we say placenta previa, it means placenta is in the lower uterine segment. Now when we are saying vasa previa means vessels are in the lower uterine segment. So when the vessels are in the lower uterine segment, then whenever this fetus will put pressure here, this will rupture and it will bleed. Fetus blood will come out of the vagina. Okay, and it is a serious complication. So it is due to the vasa previa. Okay, so that was all about the filamentous insertion. In short, I would like to tell you, the Succenturita placenta is the placenta in which there are, in addition to the main lobe, there is a small lobe there, and the complication which it gives is usually secondary PPH, subinvolution, and sepsis. And this is the this is a circumvallate placenta. And circumvallate placenta, the chorionic plate is small, so it leads to APH and IUGR due to the fibrin deposition. And now this is the battledore placenta, where the cord is inserted at the margin. And this is the filamentous insertion of the cord, where cord splits before entering the placenta, and it leads to vasa previa. Okay, now the next question is, which is not a method of first trimester MTP? Okay, so as you all know, abortion is favorite topic of FMG examiners, and it's a favorite topic of NEET PG examiners too. So please focus. More chances are there. The question in your exam will be surrounding the hair only. Okay, which is not a method of first trimester MTP. So the answer is options were methotrexate, mifepristone and methotrexate, extra amniotic instillation of ethacrydine lactate, dilatation and curettage. Okay, the first trimester MTP methods, there are broadly of two types: medical methods and surgical method. The medical methods includes the drugs. So the drugs which can be used are mifepristone, misoprost, methotrexate, tamoxifen. So instead of mifepristone, sometimes we use tamoxifen and misoprost combinations also. The another drug is surgical method. Sorry, another method is surgical method, and in surgical method there are mainly four procedures: menstrual regulation, MVA, suction evacuation, and DNC. Okay, so that was all about the first trimester method. Okay, and about the second trimester method, what are the medical methods includes mifepristone and the prostaglandins, which includes both misoprost and carboprost, and sometimes we also give oxytocin infusion later after inducing it with prostaglandin. And the other procedures which are used are extraamniotic instillation of prostaglandins, mainly E2 and F2 alpha is used. E2 is dinoprostone and ethacrydine lactate. In another procedure is intraamniotic instillation of hypertonic urea and saline. These also cause second trimester abortions, though these are not practiced in clinically, but you can see examiners do ask all these things because in the era of the examiners these were done. Okay, and the surgical method for use for second trimester abortion is DNC with ovum forceps and suction evacuation or hysterectomy. Okay, so this was about the methods. Now this is one of the most controversial question. As per WHO, minimum number of ANC visits. So answer to this question is 8. Here I would like to add here that in 2018, in it has changed. WHO has said that at least minimal ANC visit should be 8. Okay, and if in the question the words are focused ANC, then the answer is 4 focused ANC visits, or minimum number of visit as per government of India, because in India there is lot of population explosion, so we have lesser number of health workers. So in government of India, the minimum number of as per government of India, the minimum number of antenatal visits is 4. I hope you understand. The next question is first sign of magnesium toxicity. Now you all know magnesium is the most hot shot favorite topic of the examiner, and I think this was a question which was asked in FNG August 2020 on the NEET PG 21. See how the questions repeats. So these all are PYQs. Okay, so let's see what is the first sign of magnesium toxicity. So the first sign of magnesium toxicity is loss of deep tendon reflexes, because magnesium has a very narrow therapeutic range, 4 to 7 milliequivalent per liter. If the magnesium values goes above this range, then there is a CNS depression and respiratory depression and heart cardiac depression. So if it is the values are in 8 to 12 range, the serum concentration of it is 8 to 12 range, that is milliequivalent per liter, then there is 8 to 12 milliequivalent per liter, then the deep tendon reflexes are lost. Okay, and if it is 12 to 16, then there is respiratory depression. At the range of 25, there is cardiac arrest. Okay, so that is why we always keep on monitoring whenever we give the maintenance dose. After giving the loading dose, whenever we give the maintenance dose, first we check these things: deep tendon reflexes and respiratory rate, and the third thing which we check is urine output, because it is not that this magnesium is affecting the renal system, but we check the urine output, because the only source of the excretion of the magnesium is the renal system. So if renal system is shut down, as you know, renal system quite often gets affected in the preeclampsia and eclampsia. So if this renal system is going in failure, then this magnesium will not be excreted out, and it will simultaneously it will lead to magnesium toxicity. Okay, so now let's go to the another question, which is, what is primary amenorrhea? Okay, now it was framed in somewhat different, the question framing was something different. So that is why I always tell you, student, please go for the extra expected question. Don't always expect कि same terms use होंगी and same words use होंगे, options same होंगे. So topics are same, but the options and the question framing is not same. Okay, so let's see here. Now here they are telling that a girl of age so and so came. These four girls came, and they have not attained menarche, and they have given their breast tanner staging. Okay, so when you are going to whom you are going to diagnose the primary amenorrhea. Okay, so what is the definition of primary amenorrhea? Now you all know this, that if menses have not come, menarche is not achieved at the age 13 with absence of secondary sexual characteristic. Okay, so we will say primary amenorrhea if menarche has not been attained and there are absent of secondary sexual characteristic, and we will say primary amenorrhea if the age is 15 and there is presence of secondary sexual characteristic. As I already told you, the reason behind is that the most common reason for primary amenorrhea is idiopathic, so we wait till sufficient age. Okay, so now here if you see that here it was 4. Yeah, it is typing error. Here it was 4. Okay, so here you can see that in the question number 1, the age is 11, and secondary Tanner stage 1 is, you can say that it is secondary sexual characteristic haven't developed. Okay, and age 1 and secondary sexual characteristic absent. So when secondary sexual characteristic are absent, we take the age as 13. So this is not also primary amenorrhea. Seeing the option second, age 14 and Tanner stage 4, yes, you can say that this is primary amenorrhea because breast has been well developed, but the age is 14. Let's see other options. Age 12 and the breast is well developed. So if breast is well developed, then the age should be 15 to diagnose it as primary amenorrhea. This is perfectly not a case. And see, this is age 13 and Tanner stage 5. So at age 13 we say the age should be 15. So this is perfectly going normal. Age 14 and Tanner stage 4. Okay, now next is wrong about deceleration, late deceleration. Okay, so as you all know that CTG has 3 type of deceleration. Okay, early, late, and the one which are with the contractions, the one which are with simultaneous with the contraction. So let us see what they have asked about the late deceleration. This is a question which is exactly from the Williams, and yes, it is a bit odd question. Like this type of questions are not expected in NEET PG and FMG, but just listen here. See, they have just framed a term. You all know that if this is fetal heart rate, and what is deceleration, we know the definition is if the fetal heart rate dips 15 to 20 beats below the baseline, right? And if you see this word, this is decrease in the fetal heart rate more than 15 to 20 beats above baseline. So above baseline is not deceleration. Okay, that is it. Now let's see another. It starts and end after uterine contraction. Yes, that is what late is there. Late means that the contraction is after the late means that it is after contraction. We say it early, we say it late, as per contractions. Okay, and it is smooth and gradual. Yes, it is there, because whenever the fetus, you all know late deceleration occur in uteroplacental insufficiency. So whenever there is late deceleration, then it is going to be you going to occur in uteroplacental insufficiency. So in uteroplacental insufficiency, the beat to beat variability is lost. Okay, and it is not followed by acceleration. Yes, acceleration is in the condition of the acceleration is in the condition of the fetus, good fetus, good fetal condition. So late decelerations are not good fetal condition, they are conditions of uteroplacental insufficiency. Let's go to the next question. Not a component of biophysical profile. Here I would to like to, this is the most easiest question and most easiest to remember. See what the biophysical profile is also known as Manning score. Question can come with another name, Manning score, so you should know that it is Manning score. It contains 5 component. Okay, it contains 5. Sometimes you want mnemonic, but I think in this Manning score you don't want any mnemonic. You just listen here that its one component is AFI and another component is NST. Okay, and as these two components are the most important, so these are also known as modified biophysical profile. Okay, these are also known as modified biophysical profile. And at the number 3, 4 and 5, what are there? So this one you have to learn independently, because last time in the Inicet they have asked you what is modified biophysical profile. So this you have to learn. Okay, ki modified basic biophysical profile is AFI and NST. Okay, now let's see what are the other components. 3, 4 and 5 are the fetal body movement, fetal breathing movement, then fetal tone. Okay, so you can see it is very easy. The two components, one you have learned that AFI and NST, the another two components are fetal body movements and fetal breathing movements. So 2 movements, one is body movement and another is breathing movement, and in the last it is tone. So I don't think it is confusing or it is difficult to learn. Okay, so here the answer is DFMC. DFMC means daily fetal movement count. Okay, so because NST and NST is a component, AFI is a component, and fetal tone is the component. So here you have to know that AFI and NST is modified biophysical profile on Manning score, and fetal body movement and fetal breathing movement and fetal tone, and all these 3 are fetal components. Okay, all are causes of uterine dysfunction. Though uterine dysfunction was never asked in the past, this is not a PYQ, but still I would like to tell you, one fact, कि once a lady has delivered normal, next time it's very easy to deliver the lady normal, right? So all the problems of uterine dysfunctions or every problem in the normal delivery occurs in primary gravida. In usually secondary gravida, it's very rare that the one patient has undergone normal delivery and second time the patient is going under cesarean. Okay, so it's very rare, though it occurs, it's very rare. So here all are causes of uterine dysfunction except multiparity. So multiparity is not a cause. Okay, so all are true about calculating EDD. So this is one of the basic question which is FMG and NEET PG favorite question. That is, I always told you, this time INRCT has more so less basic questions were asked. All are true about calculating EDD except, okay, so EDD is calculated from the last day of the LMP. Yes, this is wrong. EDD is calculated from the first day of the LMP. See, in the two questions, they have just played with the words. It is not the last day of the LMP, it is the first day of the LMP. So, in exam, dear students, you are going to read each and every word very carefully, because the focus which you have in your exam is one thing, and your preparation is one thing. So, your hard work of so many years is equal to your focus in the exam. Okay, so you are all going to enter the exam with a lot of positivity. Okay, so EDD is calculated from the last day of LMP. This is wrong. Okay, let's go. And if a patient is unaware of its LMP, has forgotten the LMP, or if the patient is a case of contraception failure, then we do rely on the first trimester CRL, and that was a question of the NEET PG PYQ. Okay, and in the case of the IVF, we rely only on the embryo transfer date, and that is how we calculate the EDD. Okay, next is the sequence of DNC. What all are, what is the sequence of DNC? Okay, so all these sequences were asked, lot and lot of questions were on the sequences. So number one is dilatation, number two is curettage, and number three is assess the size and direction, and number D is sounding. So let me tell you what is the sequence. First of all, whenever we take the patient, we take it in lithotomy position. Then first we assess the uterus size and direction. Okay, then we insert the uterine sound, because when we know by assessing it clinically, doing the PV, that it is anteverted or retroverted, in that direction only we will put the sound, and we get the, by sounding the uterus, we get the how much is the length of the uterus, so that our dilator does not perforate it. So first is assessing the size and direction. Okay, next is sounding. Okay, and next we dilate it, and in the last we curate it. Okay, so once again, first we do the PV. Okay, and we assess the size and direction of the uterus, and then we put the sound in the direction of the uterus, and we take measure how much is the length of the uterus. And number third is that we dilate the cervix, and number fourth is we curate the uterus. Okay, next question is, all are true about placenta. It was the most easiest question, and first option itself is false, that umbilical cord has two vessels. You all know umbilical cord has two arteries and one vein. Left vein is left, right, and a single umbilical artery indicates lot of congenital anomalies. Okay, if there is the presence of single artery. Next question was, this was on the only one clinical question we got in the Inicet. Rest all were one-liners. Okay, so there were a lot of one-liners in Inicet this time. There is a primary gravida, and it was having impending eclampsia because patient is complaining of blurred vision in labor. Fetal heart rate is 140 and the PV is one finger and 6. Patient is also in labor. So you all know, I have told you that mild preeclampsia is terminated at, mild preeclampsia is terminated at, yes, 37 weeks, and the severe preeclampsia, they are terminated at 34 weeks. So we will not give tocolysis, or we will not give steroids, because steroids are given before 35 weeks. And here we have also to give antihypertensive and mag sulfate. Right, so that was the answer, antihypertensive, mag sulfate, and terminate. This is active management of third stage of labor sequence. As I already told you, this time lot of sequences were asked. So this is not the exact sequence. Let me tell you what is the exact sequence. First of all, after delivering the baby, we see that whether another baby is not or not. It can be a twin pregnancy which has been missed on antenatal checkups. Okay, and number two, we do give uterotonics. You almost all of you have read that line. After the delivery of the anterior shoulder, we give the uterotonic. So that is, second point is uterotonic, and third is controlled contraction. And once the placenta is out, we do massage. Okay, so the order is number 1 it is another baby or not, number 2 is uterotonics, and number 3 is controlled contraction, and number 4 is massage. Okay, last question is what is the mechanism of labor step. They've asked you to arrange those steps in sequence. That is how I learn. It is best if you do it on the dummy and pelvis, because now